Patrick Hutzel from intensivcarehotline.com with another quick tip for families in intensive care. So today's another success story from one of our clients who has their husband in ICU, and the husband got intubated after initially was put on BiPAP in the emergency department, then deteriorated quickly with respiratory failure and needed to be intubated. After about 10 days of ventilation in ICU, the family was told, that the only way forward is a tracheostomy and sending into LTAC. Obviously, this is for our US clients in particular, because this client is in the US. And then we looked at medical records and, we could see, and we knew from the family he was actually passing spontaneous breathing trials, but the ICU was trying to work them up and word them up for tracheostomy and PEG and send him out to LTAC. Now, interestingly enough, we looked at the situation and he seemed to be over-sedated with fentanyl in particular and Presidex, especially during the nighttime. And also he was physically restrained, right? He was restrained physically as well as chemically, because when you think about it, fentanyl and Presidex are chemical restraints as well. Anyway, so because he was passing spontaneous breathing trials, we suggested, that they should take away all sedation, should take away the restraints to make him feel at ease, because the restraints made him very agitated, made him very uncomfortable, made him paranoid even. Imagine you've got a breathing tube in your mouth and you're waking up, you don't know what's happened, and then your limbs are restrained. Someone needs to take the restraints off and actually bring in peace and calm to this patient without chemical restraints, and physical restraints. Anyway, so he kept passing the spontaneous breathing trials for a few hours a day, but he was still sedated. So we went back and we actually wrote to the ICU and we said, look, would be good if you could take the physical restraints off as well as the mechanical restraints and see whether he can pass more spontaneous breathing trials. And it took about 48 to 72 hours until the client got extubated successfully. Extubation means the removal of the breathing tube. Now, I have made a video a while ago where I talk about how to wean a critically ill patient off the ventilator and the breathing tube. And one of the main ingredients there is to wean off sedation. So to get a patient compos mentis, to get them to wake up, obey commands, do spontaneous breathing, and then you can take the breathing tube out if some boxes are ticked, including arterial blood gases must be good, etc. But it is another sign that the easier way out sometimes for ICUs is just to do a trach and a PEG and ship them out of sight, out of mind, because it takes sometimes a lot of work to get someone off the ventilator and extubate them. There can be some trial and error. There's a limited window of opportunity for extubation, right? And but more importantly, the ICU was sort of saying, well, we make the decisions here. Well, the bottom line is that in this particular case, when we looked at medical decision making, well, it's actually the family is making the decision. So once again, we wrote to the hospital and saying, look, it's actually not you who's making the decision, it's actually the family who's making the decision, assuming it is within safe parameters, which we thought that was the case, right? So what have I been saying for a long time? I've been saying for a long time that hospitals are very good to pretend they can do whatever they want. Well, do you think that, life or death situation in intensive care, they come with certain rules, regulations, policies, laws? It doesn't happen in a vacuum, right? You need to keep that in mind. Intensive care does not happen in a vacuum. Patients do have rights, families do have rights, and that's what we exercise in this situation, to get this patient off the ventilator and the breathing tube and not let him go for a tracheostomy and for a PEG tube and then go to LTAC. Don't get me wrong, tracheostomies have their time and their place, and I've said that many times as well. But you got to know when a tracheostomy is the right thing to do, and you have to know when to avoid it, right? But that only comes with experience. I mean, I have worked in intensive care / critical care for nearly 25 years in 3 different countries, where I also worked as a nurse manager for over 5 years. So, that is what I've been doing for a long time, and I've been consulting and advocating for families in intensive care since 2013 here at intensivecare.hotline.com. And, you know, I can say without the slightest hint of exaggeration that we've saved many lives with our consulting and advocacy, you know, or changed the trajectory of recovery like we have in this instance, most likely, you know, shortened recovery times, you know, making it possible for patients to go home from hospital rather than going to an LTAC, you know. And that's why it's so critical you get a second opinion. That's why it's so critical you get insights and education about what are your rights. You know, intensive care teams do not operate in a vacuum. You know, they want to pretend they operate in a vacuum, but they're actually not. But you have to know what to do and how to position things. And that's also one of the reasons why we created a membership for families of critically ill patients in intensive care at intensivecare.hotline.com. You can click on the membership link there and become a member there, or you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email. And we answer all questions intensive care related. In the membership, you also have access to 21 ebooks, 21 videos that I wrote and also recorded for you, so that it will help you to steer this incredibly difficult territory that is intensive care, but it'll help you to make informed decisions, have peace of mind, control, power, and influence, and it'll help you making sure your loved one gets best care and treatment. I also offer one-on-one consulting and advocacy for families in intensive care, and I talk to you and your families directly. I talk to doctors and nurses directly, and I ask all the questions that you haven't even considered asking, but must be asked when you have a loved one in intensive care. I also represent you in family meetings with intensive care teams. We also offer medical record reviews for families in intensive care, for patients in intensive care, so you can get a second opinion. Once again, making sure you make informed decisions, have peace of mind, control, power, and influence, so that your loved one gets best care and treatment. We also offer medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are simply suspecting medical negligence. Now, and all of that you get at intensivecare.hotline.com. Call us on one of the numbers on the top of our website, or send us an email to support@intensivecare.hotline.com. If you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell, comment below what you want to see next, what questions and insights you have. Thank you so much for watching. And this is Patrick Hutzel from intensivecare.hotline.com. I'll talk to you in a few days and share the video with your friends and families as well. Take care.